Good morning, good afternoon, folks, to those who are just trickling in. Um, you're in the right place. This is our webinar for co-designing an AI decision support tool with Alliance members. Just gonna wait a couple of minutes as people come running in from their previous meeting, grab a glass of water, whatever it is they need to do, and we'll get started about 12:02 or 12:03. Hello again, everyone. It's about 12:02, so we will get started. So thank you, everybody, for being here with us this afternoon. Today's webinar is a bit more interactive than the usual Lunch and Learn webinar you might be used to. So as most of you know, the EPIC Practice-Based Learning Network is co-developing an AI-enabled decision support tool for diabetes and mental health care. And today we're here to hear about the outcomes of phase 1 of this project and the goals of phase 2. But we're also going to do some thinking together about the process for phase 2. We're going to have several poll questions and discussion points during the second half of the webinar. Through those, we'll gather input from everybody here that will help determine what the co-design process will look like for phase 2. Next slide, please, Jaky. So some quick housekeeping notes are up on the slide here. The usual courtesies apply. Please raise your hand if you wish to speak and we'll call on you at an appropriate time. And don't forget to mute yourself when you're not speaking. You can feel free to enter questions in the Q&A panel or the chat at any time, and we'll address them as soon as we can. If you see that someone has asked something similar to what's on your mind, this applies to the QA panel specifically, you see that there's a similar question to what you're thinking about, you can upvote it with a thumbs up and or post a comment below it. And doing this will help us identify what's most important to people in this group, what's on multiple people's minds, and that will also help us keep the discussion flowing and logical. So as I mentioned, there will be some polls, and most of the polls will give you an option to share additional ideas in the chat as well. The webinar is being recorded. You've probably heard the little voice warn you about that. And we will share a link to the recording along with the slide deck later this afternoon or tomorrow morning. Tomorrow is Saturday. Later this afternoon or Tuesday morning. So watch your email for that. Before I introduce our speakers, I'd like to take a moment to acknowledge the traditional stewards of the land where we're virtually gathering today. Next slide, please. The work of the Alliance for Healthier Communities and our members takes place across what is now called Ontario, on traditional territories of Indigenous people. Please take a moment to read the slide and reflect on the people whose traditional lands you enjoy. My name is Catherine, and I'm a settler here. My family settled in lands belonging to the Kwakwaka'wakw people on the west coast of Turtle Island. Throughout my life, I have lived in the ancestral lands of 14 First Nations and the birthplace of the Métis Nation. I now live and work in what is now called Toronto, on traditional territories of the Anishinaabe, Wendat, and Mississauga peoples. This land is covered by Treaty 13 of 1805, the Dish with One Spoon Wampum Covenant of 1701, and the Two Row Wampum Covenant of 1613. In the spirit of these wampum covenants, I commit to sharing and preserving the land and its resources, taking only what I need and leaving the rest for others and for future generations. I invite you to share your personal land acknowledgements in the chat if you wish to do so. Next slide, please. And now it's my pleasure to introduce our two presenters. Dr. Jaky Kueper is a senior research epidemiologist at the Scripps Research Translational Institute and a Knapp-Cragg Phillips Futures Fellow. In 2022, she completed the first ever interdisciplinary double PhD in epidemiology and biostatistics and computer science at Western University. Among many other projects, she is currently facilitating the co-design of a decision support tool with the Alliance's EPIC Practice-Based Learning and Research Network, and that's what she'll be talking to us about today. Sara Bhatti has worked at the Alliance for Healthier Communities since 2018, when she co-led the evaluation of RX Community, Canada's first social prescribing program. Sara is now the research and policy lead, working closely with our Director of Research and Evaluation on numerous projects that advance measurement and learning in our sector. Sara is currently supporting the Alliance's EPIC Practice-Based Learning and Research Network alongside Dr. Jaky Kueper. And Sara will be helping Jaky with today's presentation, supporting, moderating the questions and chat and so on. So Sara and Jaky, thank you both so much for being here, for sharing your expertise with everybody in this group. And my name, again, is Catherine, and I work as a knowledge translation specialist here at the Alliance for Healthier Communities. With that, I'm going to turn you over to Jaky. Thank you so much.
Wonderful. Thank you so much, Catherine, for the introduction, and thank you everyone for joining us today. I'm very excited to tell you about this project that we've been working on. And I just want to call it, we do have a few of our PBLN members here as well. And so Sara's going to be in the chat, and I think everybody is welcome to put in ideas and questions as we work through each section of this webinar. And then when we get to the end, we'll move to a more discussion-based time. But if you have pressing questions, we can stop and answer those in the meantime as well. So as Catherine mentioned, and as you probably saw in the webinar announcement, we're working on co-development of a diabetes and mental health care decision support tool. And so we're going to tell you a bit about where we started, what we've done so far, and where we're going. And then we're going to sort of dive in and pick everyone's brains to hear where or what you think we can do to have the best success in the second phase of the project. Okay, where we started, a brief introduction. So backing way back up to why we're sort of here and why we're able to do these types of projects, it has been large increases in everyday data. And these are data that are just generated as a byproduct of people going about and living their lives. And so you can see on this chart that there's been exponential increases, especially over the past few years. And notice that the y-axis is in zettabytes. And so a zettabyte of data, one of them would fill about 20% of Manhattan in New York. So we're talking about a lot of information that's out there today. And a lot of this information pertains to health. And so we can use these data in ways to support health and well-being. For example, asking questions about what happened in the past so we can learn about things and inform the future, and then also building tools that can help us to make predictions and inform care prospectively. We're focused on sort of that second use of these data in this project. And even more specifically, as you can imagine, there's all sorts of data from all kinds of different places. And in this project, we're really focused on this scenario where community health centers are generating electronic medical records that have a lot of important information about the populations that CHCs serve. And so we can analyze those data to create decision support tools that are then used right back in the same community health centers that originated that data in the first place. And so this kind of cycle of internal decision support tool development fits nicely within the learning health system framework and all of the broader work that's happening around that at the Alliance and with EPIC. Is this commitment to using data to inform or improve care. And so again, within a learning health system, there's a lot of different things. There's research studies, quality improvement, and then what we're focusing on today, which is decision support tool development. And so this is one of the first projects that has involved within EPIC and the PBLN an AI-enabled decision support tool. And the reason why AI, artificial intelligence, is important is that, like I said, with all of these data, and they're large, and they can be messy, and they can be granular, and sometimes, not always, but sometimes, AI techniques help us to better understand and derive more meaningful or precise insights from those data. So the place where the AI comes in is most likely between the EMR records and the decision support tool stage, and sort of developing it. And for those who may be less familiar with what AI is, I always like, whenever I'm given a chance to chat about an introduction to AI, I always start it with Ada Lovelace in the 1840s. A lot of people started about 100 years later, but I like to think about one of the first building blocks of AI, which is an algorithm. And Ada Lovelace developed the first algorithm. It's a process or a set of instructions for a computer to follow to execute a task or solve a problem. Technically, AI wasn't formalized until about the 1950s, and then today it's advanced a lot. And the thing that distinguishes sort of a regular computer algorithm with an AI algorithm is that those tasks that are being performed by the computer are said to have some sort of intelligence. And so there's a lot of different intelligent tasks you can imagine. I've put the 5 main ones up on the slide. Today, what we're focused on is the predicting pre-specified outcomes one. And we're going to talk more about that soon, but it's the idea that, again, we can use these data, find patterns to help predict what's going to happen in the future. Lost my clicker. Okay. And the main field about how computers and AI are able to do this is called machine learning. And machine learning is kind of like a giant, it's really about pattern finding with math. So finding mathematical patterns in data. And it's really, really important, though, that math is partly defined by humans. And so what this project and a lot of this project has been about, and some of the things I'm going to chat about at the end, is what are those decisions that we, as the humans that know what would be useful for CHCs and our clients and our care providers, staff, and everyone, how can we encode that rich knowledge and expertise into the math, as well as deciding what data to use and how to use them. And that's also going to influence that math that's ultimately finding that pattern between what happened and what we think is going to happen in the future. Okay, now you can imagine, I just said there's tons of data, there's tons of things that we can do with these data. So how do we decide, right? Because there's limited resources and capacity, not everything is going to work well. And if we design tools that don't work well, we can actually do more harm than good. And so phase 1 of this project is all about trying to find that sweet spot between what's possible, what's possible, what's feasible, and what's meaningful. And that's actually not trivial, and that's a lot of work. And a lot of times, not enough time is spent finding that middle part, which is represented with the heart, because we want to do good and help people. And so I think it's really, really significant that we've had people that have come along and been thinking really hard, what do we do here and how do we do it well? Okay, so in a nutshell, phase 1 is about that problem selection and refinement. And then phase 2, what we're going into and we're hoping to get input from everyone here today towards is how do we now make that tool come to life? And then also thinking about what happens after and what are the future directions, both with the tool and also in terms of broader initiatives at the Alliance. Okay, so what have we done so far? I'd like to summarize it in terms of 6 stages of work. And so I'll walk through those now. So the first one is, I mentioned briefly that this is one of the first co-development data-driven support tools within CHCs. And so the first thing we had to do is understand, well, what data are available in the EHRs? And how do we use those data well? And how are clients represented or not represented in those data? Because again, thinking we want to know what are the meaningful things we can do. And so we used one type of AI, which if you saw on the slide, one of those intelligent tasks was describing past patterns or asking questions about what's happened in the past. So we actually started with that type of task, as well as some more traditional epidemiology to understand sociodemographic, clinical, and healthcare use characteristics. And some of you may have been at the webinar we did that described that study in depth. If you were, thank you, and thank you for coming back. It's great to see you again. And we went from there, and that's when we formed our core PBLN team. Again, thank you to those who have joined us. Please be vocal in the chat, sharing things, adding details, answering questions. And so this core team has had Alliance research leaders like Sara, PBLN members, and then external academic researchers such as myself. And I've held a lot of different roles in and around this project, and we've sort of found ways to stay involved, which I've absolutely loved and appreciated. Okay, So what did we do? So we got our team and we started thinking, okay, what do we want to start with, right? Like, so there's so many different things we could do within this sort of EMR-based decision support tool framework. And we narrowed it down to three main types of decision support tool that we thought would be really good and possible. And we decided to start with one around risk prediction or screening, specifically around diabetes and mental health. And so one of the things is, again, this is a meaningful target to tackle, and what do we think we're going to be able to do with this? And so again, we know that mental health and chronic conditions have a lot of overlap, and we know that there are risk factors for each other, and we know that there's also things that we can do to help people with one or both chronic condition or mental health. And it's also a very large proportion of people that do experience these things. And so by developing a tool to target this, we might actually be able to help a bunch of people in a way that's meaningful and actionable. So here's sort of the way that we first envisioned this tool would work. Again, impactful, because again, from that first study, we know there's a high prevalence of people with diabetes and mental health challenges and comorbidity. Actionable, there's things CHDs already do all the time to support people with mental health, and it's feasible. We thought that the data were available to be able to do this task really well. It's the idea is that there would be a client that comes in and is diagnosed, say, with diabetes. And what will be happening is in the background of the EMR, would be analyzing these data, right? Doing that pattern matching activity. And if someone was flagged as a really high risk of mental health decline over the next, say, year, it would notify the care provider so that they can maybe say, is this something that I want to work into their new care regime, or talk to them about it and just raise awareness, refer them to a program, or just keep it on the radar. Even maybe they don't even bring it up in that appointment, but they just are aware that this is something to be mindful of, that this person is at really high risk of mental health decline. And so that's the idea. And so one of the next stages we did, now it's step 4, is we said, okay, how well can we get this to work technically in the data? Because again, we think it will work, we think we have the data there, but we need to test it out. And so our first goal was to develop a model to predict this mental health decline within a year. And we found that in our initial sort of sandbox practice models, the predictive performance wasn't that good. So it wasn't something that was ready for clinical deployment, for example, but we learned a lot, and this was a super valuable activity. So one is we identified that, maybe there's other data sources like lab tests and medications that we weren't originally incorporating that could be good to include. And then we also thought about what are the ways that we're sort of pre-processing the data and making it available to the machine learning. And we thought of ways that we can improve that. But what was, I think, most important is as we were getting deeper and deeper in these discussions, we started interrogating that clinical problem even more and saying, what are the second and third and further on impacts that we're going to have? And some of the ways that we gathered additional input into sort of thinking about this, as some of you may have seen, we put out some bulletins and did a poster presentation up to this point. We did meet with Diabetes Action Canada to see are there relevant other things happening, or should we be connected with anyone. And one of our PBLN members, Sandra Fitzpatrick, led a discussion group at her CHCs, which was also super valuable. So if anyone attended that, your insights directly went to inform what we did in the next stage. And also that's the type of thing that we're going to try and do again. So if anyone's interested in having that kind of deeper input, please let us know in the chat and share your thoughts today as well, because I think it was a lot of fun. Okay, so like I said, this first individual level tool, at the end of the day, we said, okay, hang on a minute. If this tool works, it's going to identify either more people that would benefit from mental health services, or it might identify people earlier than they otherwise would have been, which on its own is maybe a helpful thing to do. But in our discussions, we realized that a lot of the mental health services were already at or near capacity. So if we actually implement this tool, we might end up just driving that need and referrals and that beyond what there's actually space to care for yet. And that in the end is maybe going to make things worse, or at least not help them in the way that we originally intended. So we thought there's actually a more upstream challenge here that we might be able to support first. And so that is moving from a provider level decision support tool to a population level planning tool. And so here the idea is, well, instead of identifying individual people first, can we say how many people at a group level do we think are going to require mental health services in the next year? And then what we might be able to do is say, okay, does that align with what we have available? And if it doesn't, maybe it can be used, for example, to advocate for more resources or other sorts of things to make sure that we're going to have care for everyone available for everyone. And that could look like a lot of different things. It's not necessarily one type of solution to meet predicted need. And then the other things that we found in this tool is that we learned things from the first sandbox study. So our predictive performance was better, right? So that technical work was better. And then we also identified some areas that we want additional input on, things we're not yet sure about. And that's one of the things that we're going to talk about later and that we want to cover in the focus group is how we still know there's things we can do better. And we want to hear from you what those are. Okay, so here's sort of our little high level summary of what we did. So one is we scoped out, we figured out what do we think are the meaningful things to target. We started with an individual level case study, and then we moved to a population level case study. And we also learned a bunch of other things along the way. Like I said, this is a pretty new type of work, not just within EPIC and the Alliance, but like globally as well. Not a lot of people are doing this really intense co-development work of AI tools in primary healthcare. So we had a bunch of different insights. And one of them that I didn't talk about, but we also maybe can talk about a bit more later, was this idea that we're focusing on one tool to start because we need to learn how to do that well. But we know that if we want this to be a broader initiative that grows and gets bigger, we do want to figure out how are we going to coordinate between these different tools. And we don't necessarily want to just develop 100 different things. So we're starting with one to learn how to do it well. But one of the other things, if anyone has ideas to think about, is like, what are the next steps as we start to think about more and different options? And then also just the interdisciplinary teamwork and people with all different perspectives was so valuable. Okay, so then we paused and we said, all right, we've done a lot of work up here. There's sort of three main directions that we could take this project in. And they have different sort of resources and feasibility and ideas. And so one was to pause and share. The other was continue the individual level tool direction. And the third was to continue the population level tool direction. And the first thing we decided to do was to pause and share what we had done in phase one. Both to let people know, and I'm so glad if anyone has seen, there was some emails that Catherine sent out and a 2-pager and kind of sharing what we're doing. And then we also did a more academic research publication. And as an example, someone from Brazil recently reached out to me and was like, I saw this paper of the work you're doing. I'm trying to do similar things with CHC-like communities there. And they were like, it's so cool to see somewhere else that is like thinking so carefully about what's meaningful for their populations and how to do it really well. So yes, we're focused on developing things within the CHCs here, but know that other people are also like really excited about our approach and learning from it as well. There's some secondary impacts there, which is cool. Okay, and now then we were like, okay, let's continue this population level tool, which you probably saw coming based on the way I introduced the first phase. Okay, so now where are we going? All right. So we have 3 goals for this next phase of work. So the first one is we want to refine the model or the math, right? And how we want to do that is we want to get extra input from people like yourselves who are here and those who will join the focus groups. And then we want to retrain, so re-identify those patterns with a more recent data. Then we want to share that tool with end users and try it out. And so I'm going to show you in a minute more of the details about how we initially do that testing. But we want to get it where we're actually making true future predictions. And then again, thinking about expanding the decision support tool initiative. So I'm going to re-describe our current vision and thoughts about how this population level planning tool would work in practice. And again, remember, we're going to go back and be refining this. So please share thoughts and inputs and questions because none of this is super set in stone yet. But what our main idea is, okay, so we have current clients with diabetes. So we'll estimate the number of clients with future mental health care needs. So one of the things is, how do we identify mental health care needs in the data? So if anyone has great ideas about that, please join us in helping us to solve that better. And so again, we would use machine learning to make this prediction, compare it to what's planned. Oh, sorry. Next slide's less scary than it looks, I promise. And we'll compare it to the planned amount. And if they don't match up, maybe there's something we could do to try and get it closer. And in particular, if the planned resources and capacity are less than the predicted. If they're over, we're less worried, right? So it's kind of a one-directional thing. And maybe it's advocating, maybe it's in a report, maybe it's brainstorming, shifting things around, thinking about, is there some sort of group program, all kinds of different possible things here. So if anybody also is interested in that sort of like endpoint, where do these findings go and what do we do with them? That's another big area that we want to chat more about. I have like 3 slides that are more method-y, for in case there's anyone here who likes that. If you don't love the methods details, that's okay. We're going to come back to more broad discussions as well in a minute. But I did want to get into the nitty-gritty. And one of the things that was so valuable about phase 1 is that we were able to take insights from all different sort of perspectives and build them into technical, granular decisions. And that's the power of interdisciplinary work. So, okay, so what do we do? So you can build this sandbox case model. So our eligible cohort, primary care clients with diabetes in 2016 to 2018, were about 20,000. We compared 3 different types of prediction models. So anything from logistic regression, which is kind of like a simple linear, more statistical model, also which introduces some sort of or automatic feature selections, figuring out what variables are or are not valuable, and then cat boost, which is one of the sort of cutting edge prediction models for machine learning now that is very complex and can look at much more different types of patterns as well. And the way that we first, in our sort of test case, we're thinking about estimating mental health need, and this is also partly because we had started with that individual level tool, is people who had at least 1 ENCODE FMCODE in 2019 within these groupings. And so that's something that we think is a really good starting point, but we flagged as, okay, maybe now that we're focused more on the population level, there's other things that we could include in that as well. And then the types of input data we used was sociodemographic, healthcare use, and care history information. Okay. And so now what I'll describe is so one of the ways that we sort of test out the model in the sandbox environment is we use it all on data that already happened. So we know whether or not someone experienced the outcome. And we compare basically whether or not the machine learning model predicts that someone will have it, and is the prediction match whether someone actually did or not. It's kind of like a peekaboo type scenario. And so the number of overall clients that were predicted to have mental health indications is just over 3,000. And the ones who actually did was 4,500. So it's underestimating a little bit. And the best one was the cat boost model. And we just use anyway, this is a detail for anybody who's really into how we transfer outputs that are a probability into a yes, no answer. And on the right is showing the calibration, which is saying, does the number of people that are sort of predicted across a probability range match the observed populations? And a perfect one would be a perfect diagonal line. You can see that they're all doing pretty well, which is great. And like I said, the previous slide was overall results, but we can also see that it varied by CHC. And the accuracy actually ranged from 64 to 97%. And so this chart is just an example of some of the things that we've done in the PBLN and sort of figuring out, do we think this is working well enough that we could go somewhere? And so the pink bars are, again, the predictions, and the teal bars are the actual number of people that experience the outcome for a subset. And you can see that it's doing pretty well in some instances. In some other instances, it's a bit more far off. So again, room for improvement, but there's a lot of potential here. And so these are kind of some of the conclusions that our group has going into phase 2. So one is that we think that performance is looking pretty good, but we think we can do better. So we want more input to further refine those technical decisions. The other one is that we know there's a need to advocate for adequate mental health support. That's not necessarily specific to diabetes, but it is certainly the case there as well. So again, we want to figure out better how could this tool be used by different, and who's going to use it, and other things we can do to modify to make it as easy as possible and as impactful as possible for those potential end users. And then finally, like I said, this is the first time we're trying to do this. And so we want to learn and build on it and figure out how to do better in the future. Also, if you have ideas that are more like process related or next step related, that's also great. And this is our timeline. So today's our webinar. Then focus groups. So I hope that, I would love if everybody here joined us for a focus group, or if you have friends or colleagues or other people you know might want to come, please pass along the information for them. We're going to ask everyone who joins a focus group to listen to a recording of this, or if you're here, the live version of this webinar. So everyone kind of comes in with this baseline knowledge of what's been going on. And that's also important because some of the questions we're going to ask you very, very shortly are about how would be best to gather more information, and what are the types of information to ask. And so imagine that you have your prior of how much information you already know is what we've just shared with you now. We're also holding a workshop at the upcoming Alliance conference, and that one's going to focus a bit more on the next steps of how do we think about broader visions, and do people have other ideas and things like that. So if you're at the conference and you're excited about that, and you're like, I would love to think about other tools, other ways of doing things, there'll be some brainstorming that happens there. And then we're going to take what we've learned from today in the focus groups and we're going to update that model. We're going to try it out and then move on to the next stage. All right. So this is where we get into the more interactive part. I just wanted to first show an example of what it looks like from sort of the side of the PBLN discussions. So one of the things that we had done, don't worry, you can't read this, and the point is not that you can read it. I just want to show that when we were thinking about where and what are the places that we want additional input from, we started dividing it up into sort of who is the tool relevant, like who are the clients that we want to be predicting mental health care need for, how do we define that outcome, what's the time scale, what's that prediction interval look like, what are the input variables, and then most importantly, what's the envisioned use. And so we've sort of done some thinking about what are we pretty confident in based on what we learned from phase 1, right? Because we've already done a lot of work here versus what do we really want to have more input on. And there's probably also things that you're like, you should get input on this, and they're not even on the radar. So also, if we're not asking the question you thought we'd ask, that's good too. All right, I've lost my clicker. Okay. So we're gonna move into some polls, which I'm now realizing. Catherine, do you have control of the polls?
Yeah, I have control. So do you want me to launch the first poll now?
Yeah, let's launch the first poll now. It just kept this slide up. It's the same one we saw earlier, just as a reminder of what we're talking about. So we ask everyone to envision. The first question is, who do you think would use this tool directly? And ask everyone to enter. And of course, please add more chats and ideas. And please sign up to join us for the focus groups as well. Sarah's putting a form in the chat. So if you're like, I'm already sold, I would love to have more discussions, please sign up there.
So people are still thinking, so the answers are coming in.
Yeah. Perfect, amazing. And again, feel free to add details in the chat if there's more thoughts that you have. Or if you're like, I want to use this tool myself, I'd love to try it out as an end user, let us know. Or you can email Sara if you don't want to put that on you want to let everyone know.
You can also let us know in the chat if anyone's missing from this list that you think is an intended user as well.
the answers have stopped coming in, so I'm going to end the poll and share the results. So yeah, Jaky and Sara, can you see the results there?
Yeah.
Great.
Yeah. So this is great. So I see that there's one administrative staff is a 0. So everyone like unanimous on that. Health system leaders and providers, data management coordinators, diabetes education center staff, and clients. And I'm curious, I don't want to put anyone on the spot, but does anyone want to like share more about their thoughts or answers or ways? It's okay if we don't want to win the discussion. This is useful. I'll chat a little bit more if people are thinking about whether they want to comment. Because we were thinking health system leaders and diabetes education center staff, I think were the two that were top of our radar. And so I think it's really great to see that the DMCs and providers and even clients are also on that list. And so making sure that we get input from all of these groups in our next stages.
For sure. I'm going to stop sharing this one. And let's move on to the next poll. Are you ready for the next poll, Jaky?
Yeah. I think we'll just go, I think we'll do a series. There's maybe 5 or 6 of them, and we'll do them, we'll chat between each. But the rest of our time is really discussion and working through these polls. And so please chime in, have other thoughts. Okay, so this next question. Oh yeah, go ahead. Is when further discussing the potential tool in a focus group, you want to prioritize topics. So please prioritize the following topics and add any topics that are missing into the chat. And so the idea here is that each focus group is going to be about an hour. There's only so much material that you can cover in an hour. And so here we're asking you to think, okay, if you're joining a focus group, what do you really want to provide input on first? And that should be highest priority. Be like, absolutely ask me about this. I want to tell you so many details about eligibility criteria, for example, and that's who's the tool relevant for. Or the outcome definition, which is how are we going to capture mental health service need in the data? The prediction interval, that one's like, how far out? So in our sandbox model, we said we're going to predict needs over the next year, but maybe that's too long or too short. Or maybe there's a particular date that would be best to set these predictions for, right? Like, is it the start of the fiscal year? Is it the start of the calendar year? Is it every quarter? Those types of questions. And then ideas about the input data, what information you think is really important to help inform these predictions, how it'll be used. Is it going into a report? Is it like a dashboard? People presenting about it to their various care centers or something else.
How are the responses looking like, Catherine?
About half people have voted. This one takes a little longer because it's, thinking through rankings. So I want to give people another minute or so. Some people may be still thinking through their rankings.
Yeah. And if anyone also wants to add more details by chatting or putting in the chat, if you're like, I don't love ranking things, I just want to
for sure.
discuss,
Like,
that is more than welcome.
100%. Or if you're thinking like, I
Yeah.
want to rank all 5, but I have a really strong thought about what's most important or what's least important, and you just want to get that one thought in without doing the whole ranking exercise, chat's here for you.
And
Yeah,
also
absolutely.
let us know if you want Jaky to go over any of the possible answers as well, like intended use or outcome definition.
Yeah, maybe just put a thumbs up if you want to hear a bit about that. All right, well, I think I'm going to take the silence here as indication that people are ready to move on. So we're going to end the poll. We've had 7 people have took up our challenge of doing this ranking exercise. So you can see the results there. I think you've got some considerable differences of opinion amongst the group. So
yeah, this is interesting. I would love, I mean, no pressure because I know it's group study. If anyone does feel like adding some extra details in the chat, that would be great. Or if you join a focus group, you can also tell us there. But yeah, it would be really cool to know a bit more about what people are thinking about. I'm like processing the chart. So input data as highest priority, which is really interesting. And I guess that aligns because a lot of what we chatted about between case study 1 and case study 2 was the input data, and we had made some modifications. So I'd agree that we can probably even further refine that, which is great. And then outcome definition, which is great because that's also how we feel like in our coming into this, you're like, okay, we know we need more help with the outcome. Perfect. Eligibility criteria.
So, and we did hear from one person who sent a DM over here saying that they couldn't submit their response to question 2. So if anybody else ran into that problem, feel free to just type your answer in the chat.
Yeah, please do.
Or raise your hand if you just want to talk, you don't feel like typing, just raise your hand and we can unmute you.
Yeah, absolutely. Also, any of the other PBLN members who are here, if you want to chat and say things that I've missed or I'm not emphasizing, please go for it. Oh, this is very helpful. Okay. Eligibility higher. Cool. Great. Yeah, and one of the things I'll just speak to that about the eligibility one, because one of the things that we had thought about, again, in our original formatting, we had focused on ongoing primary care clients. But then we thought we actually probably in the next round also want to include diabetes education center clients. And there's going to be some overlap, but not necessarily complete. And so thinking about how do we identify who's in that second diabetes education group, and are there other groups that aren't captured in the ongoing primary care client category that we should add in? So that's good to know that people have more thoughts on that. We'll definitely raise that. All right, next one. Okay, so this one is again thinking more if you're going to come to one of these focus groups. You've heard sort of what we've done in terms of an overview. And if we were tackling especially some of the topics that were rated as more higher priority, how would you want to, what would be the most effective way, do you think? If you were in a room with different people, some of whom maybe you know, maybe you don't know, chatting about these things, what would be the most effective way for you to share your ideas, and or what would be the most interesting and valuable for you? And so we can have open-ended discussion where we kind of throw out, kind of like what we're doing here, throw out some questions. People can pick up on them and discuss as much as they want. Semi-structured Q&A, where again, it's a little bit more bound, very specific questions. So for example, we'll take eligibility, like, do you think that we should have only on oh my gosh, sorry, ongoing primary care clients, also diabetes education clients, also this, where we kind of lay it out very specifically, or another idea, in which case, please let us know. And again, chat and discussion is also welcome at this point.
Okay, well, we're going to end the poll there with 7 votes.
Amazing. Well, this one is probably the most unanimous that we've had so far, at least in terms of a sort of narrower amount, open-end discussion and semi-structured Q&A, which is great. And we can absolutely do that. All right, I say we have a couple more, 2 or 3 more, and then we'll also have time for general questions after. So you're welcome to start entering them as well too. Okay. So the output of the tool will be a predicted number or proportion of current clients with diabetes expected to require mental health care in the next X time. In our case study, it was 1 year, but like I mentioned earlier, we have questions about that. So do you think that the exact date that predictions are made and for how long is a hard question? So for example, you might just know like, yes, yearly, January 1st is the way to do it. In which case you would answer no to this. So it's not a hard question because you could probably just tell us in the chat right now what you just are pretty sure of. Or do you think that there's a lot of variability? That some people are going to want predictions over the next year. Other people may want predictions over each month or quarterly. And so we're just not sure. What do you think? Is this controversial or not controversial, but are different time frames more helpful or less helpful for different people or end users? And again, if you have ideas, chats, let us know.
All right, I'm going to call this one. Just had 5 votes, so may want to get more discussion on this one later.
Yeah, okay. Great. That's not yes, no. So yeah, I think some more discussion. So maybe we'll go through and then maybe if we have time at the end, people can share more thoughts around why they do or don't think this is a tough one.
Next question.
Okay, so this is the idea that this is one purpose of this webinar. So one is to share widely for interest's sake and to let people know what we're up to. But another purpose is so that people can come into the focus group ready to discuss. And so this question is like, if you were in the focus group, regardless of whether or not you actually want to attend one, do you feel like you're ready to discuss some of these questions that we've chatted about? Or would you like additional materials to come in? Because again, during that focus group time, we kind of want to get as quickly towards discussing. And I mean, we'll obviously answer questions and clarification and like that, but we want to make sure we're using the time in the most efficient and valuable way. And so if there's extra resources that would be helpful before you were to join, please let us know. And while people are putting that in, I'm going to go to the next slide, which we're going to open up for Zoom extra questions, but also if you haven't taken a look at the form that Sara put in, or you can email her directly if you're interested. Our initial times for the focus groups are on the slide, but again, if you can't make those, it doesn't mean there's no opportunity for you to be involved at any point in time. We just thought it was easier to start. Okay, Catherine, I see you
So, I invite people to share thoughts in the discussion, specifically if you're thinking you need more to feel prepared. To put something in the chat about what kind of extra resources you'd like to see. Is it written materials? Is it some interactive training? Is it just like a chance to sit down and chat with Jaky and Sara to, have some questions answered? An infographic.
Yeah, that's great. And then also, what part is it? You want to learn more about diabetes, about mental health, about decision support tools, data, all of that. Please do let us know, because we absolutely would love to do that.
So we're going to go on to the last question.
Okay. So our last one here. So this is, again, imagining in a focus group. There's a balance between wanting people to give really specific answers. So for example, in some of the discussions we have at the PBLN, we're like, do we use this encode or that encode, or like how many of them, or how do we group them together, like very specific things, versus talking more general terms about how the Unity tool will be set up, how to make it come to life with data, and how to fit it into practice and reporting, where later it's sort of transferred into more specific technical details or outputs. And so we're curious, like, what level of detail are people most interested in chatting about? So is it high level, right? Thinking about how we use it in this or that? Is it mixed? Or do you really, you're like, yes, nitty gritty is where we're going with this focus group. I want you to put up on the screen a list of encodes, and like we can chat through them. And it might be a bit or other. And like one of the things maybe I'll also add is here we're asking more about what types of input to prioritize and to do in the focus group. But of course, there are other ways to give input at any level of detail outside of that, if you want to have extra meetings or over email or things like that as well. So this is not a question about what type of input you ever want to have, but more what would you like to have in a focus group setting.
All right, 7 people out of 9 that are here have answered. So I'm going to end this poll and share the results. It does look like mixed has a pretty strong lead here.
Cool. Okay.
I also want to just note from the chat that one of the people, saying extra resources would be great. Has specifically said maybe start with some written materials with some infographics, and then, if need be, an opportunity to chat with someone.
Okay, great. That's very helpful.
And then somebody else, I guess, talking about more information, and Melita, I might call on you to elaborate a bit, because your writing is very lean. But it says more info: how expensive, accessible the AI tools, and in your test, why some test results had more discrepancy. So I guess just looking for, if you can fill us in, Jaky, maybe now, or maybe that's something to put in follow-up materials just about that.
Yeah, so how about we chat about that now? I can start to address some of that now. Maybe I'll put up just the last thank you slide if you want to contact any of us. Here are our emails. But yeah, in terms of, it's a great question, and it's a really important question, particularly around, actually, Melita, did you want to provide extra information? I might ask it for the next part, but I know around costs. One of the things, there's a lot of in-kind work happening behind this tool by our PBLN members, the data and the data teams that go right into being able to make these tools, and computing resources. And so for this particular tool, there are mechanisms and avenues in place to develop it in that way. But there are also maybe unseen costs right? So what if it breaks at some point and then someone has to fix it? Or what if we figure out that we need some sort of extra, I don't know, data or input or something that actually does cost money? And then where do those resources come from? You also might be thinking expensive in terms of like risk benefit, right? So what if it makes really bad predictions? Is it expensive because then we have a bunch of people that are trying to do actions based on something that doesn't work very well? And that's why we try and do really rigorous testing, but that's another way that costs can come in. And then I think in terms of thinking about expensiveness for like future tools and building this in different ways, I think that's one of the things that we're interested in for like, we want to see like, can we do this one really well? And then what does that look like in the future in a sustainable way? And I'll take a stab at the second part and then maybe you can add more questions, but this is, in terms of accessibility and discrepancy, that's one of the things that we need to discuss more and test more for. So, like I said, we initially built it at sort of a cross CHC level, but then maybe one of the ways it's used is actually specific within CHC. And so it might work really well for certain CHCs and not as well for other ones. And there are things that we can do to adapt the tool to specific CHCs. So if it's really not working well for one, we'll identify that before it goes into use. So we're not going to make sure that no one is using one that didn't pass the testing. But then there's a lot of questions about like, why isn't it working as well in particular settings? And is it something about the particular way that services are run, the particular client population? And so that on its own can be a whole other project and question. And so I'd say that ties into the accessibility. It's like, if our sort of base model works well, it will be more accessible because it will be a direct output of this project. But if more work is done, if we can identify why, that's great. But if not, then that's an issue. And then maybe the final point is we're developing these tools for use specific to CHCs. So we don't expect them to work for other healthcare organizations or primary care models. And that's fine. That's a decision that we made explicitly to try and tailor them to work the best for this context. But certainly our methods and processes can be followed by others. So please let me know if there's other follow-up questions related to that.
Jaky, I'm curious, and coming back to the question about why some test results had more discrepancy at different CHCs, and I think you mentioned something about, is it something to do with that, the population group? And I think it would be interesting to see if there's like an equity stratification there that could be done, if the test results are maybe more accurate for populations who are better represented in the data, or better represented in the health literature more broadly, things like that.
It's a really great idea. Because we start off by CHC, but even within, there's a whole different ways that we can look at that. And I love the examples you gave. And if there's other examples or other people have ideas of what types of clients you think this might work better or worse for, please let us know so that we can look into that. Because absolutely, we want to do, that would be something part of the testing. There's something called fairness in the AI world. And it's this idea that like, are predictions fair across different subgroups? And so we will want to do that in our next phase, but figuring out who do we test fairness for, or in what ways? Is it time-based, is it CHC-based, is it client-based? Is something else we'd love more input on. But I love that idea.
Thank you, Jaky, and thank you, Sara. I see that it is 1 o'clock, so we would like to release everybody. people can get on with their day. But I want to thank you both for your time and your expertise here. And I want to thank everybody who joined us, put on your thinking caps, thought through these difficult questions with us. And of course, our email addresses are all up on the screen there. So if you think of something, you wake up at 3 in the morning and you're like, oh my goodness, how did I not think of saying that in the webinar? Or, maybe you just, didn't feel comfortable asking a question in front of a bunch of your peers, but you want to just privately send it our way, feel free, hit us up anytime. We'll love to have as many ideas and thoughts as you all have to share with us. Again, thank you so much to Jaky and Sara. We will be posting the webinar and the slide deck from it up on our website, and we'll be sending an email out to you this afternoon, or more likely Tuesday after the long weekend with that. And it will also contain that link to the survey that we would love for you to fill in about getting involved with the focus groups, signing up for a session. And please do share this opportunity with your colleagues and your friends in the sector, because the more information we get from the more people, obviously, the better we can do. And any final closing words, Jaky or Sara?
No, just thank you all for showing up and participating in the Zoom polls. And we sincerely hope you consider participating in the focus groups, because we'd love to hear more from you.
Thank you. And have a great long weekend, everybody. Take care.
Take care, everyone.